Good evening, friends. My name is Dr. Rajadhar, and I head the Department of Pulmonology at the CK Birla Group of Hospitals in Kolkata. I'm here to welcome all of you for the Indian Chest Society webinar on sleep-related breathing disorders. Now, this is Module 3. You've heard Module 1 and Module 2, and the feedback for both modules has been excellent. Let me take this occasion for congratulating the Indian Chess Society, congratulating Dr. Amita Nene for putting together a wonderful module. There's multiple other modules to look forward to. So make sure you attend. Make sure you come and attend the workshop. There'll be 4 workshops and you need to attend one of these to get certified from the Indian Chess Society on sleep medicine. I hope you find today's meeting as engaging as you found the previous ones. Today, our topic is on diagnostics, and I have a great faculty with me. The way we run this program is to start off with a talk. The talk will come from Dr. Priya Ramchandran. All of you don't know Dr. Priya Ramchandran. She is professor and head of department of pulmonology at St. John's. She's got multiple presentations and publications. Her areas of strength, her areas of research interest, her area of academics are ultrasound in respiratory disease and, of course, sleep medicine. She's got fellowships from the Indian Chest Society, IABP, IASSLC, WSS, and WinFocus. And when you hear her, it's a treat, and she will cover the length and breadth of diagnostics in sleep medicine. Post that, we will start off with the panel discussion, and I've got the panelists lined up with me just now, but we'll wait for the introductions till after Dr. Ramchandran's talk is over. I also need to take this occasion to thank CIPLA, who's been partners for the entire sleep module and for multiple other activities of the Indian Chest Society. Hitesh, who's coordinating this on behalf of CIPLA, also needs a big thank you from our side, from the Indian Chest Society side, for putting in a lot of hard work to ensure that you get the very best in teaching in sleep medicine. I'll not delay you any further. Thank you for all the delegates who've joined in. I understand there's more than 1,000 delegates who've already joined in to listen to Dr. Priya Ramchandran and then the panel discussion after. So I won't hold you any longer. And I hand over to Dr. Priya Ramchandran for the talk on diagnostics in sleep medicine. Over to you, Priya.
Once again, thank you, Dr. Raja, and thank you for this kind introduction, and thank you, Amita, for this opportunity, and ICS also. So let's start. So is my screen visible?
Not yet, Priya.
Oh, okay. Is it visible now?
It will be in a second. It is now.
Yeah. So we've seen in the previous webinars about when to suspect OSA. So today we'll take it next forward. Yeah. So if we are going to assess sleep, it is in both a subjective domain and an objective domain. In the subjective domain, we ask the patient about the experience of the individual, which we normally as sleep physicians don't do that, but I think we should make it a practice to do that to all our patients, especially after we prescribe the CPAP. Because many of them still complain that their sleep hasn't been of a good quality. So we are not technically trained to assess that. We should develop training for that also. Of course, that's outside the purview of today's meeting. So when do we look at subjective? Some examples are for insomnia and restless leg syndrome. So for that, you don't need to do a sleep study. It's enough to do just a subjective assessment with questionnaires. And objective measurements, which we are all very familiar with, is the polysomnography, in which we are all used to numbers from spirometry to everything else is numbers for us. So When coming to questionnaires, they assess the sleep problem, and the effect on the daytime functioning of the person. So you can see there are more than 100 questionnaires. One domain which is assessed most commonly by all of us is the excessive daytime sleepiness. That is by the Epworth Sleepiness Score and Stanford Sleepiness Score, most commonly used. I'm not going into detail of all the ones that are used. And in narcolepsy, especially, there is a cataplexy questionnaire. So every domain of the sleep medicine, every domain of the sleep complaint has a separate questionnaire. And most often, we tend to ask everything together. So Epworth Sleepiness Score, the take home message from this slide is that Epworth Sleepiness Score doesn't assess obstructive sleep apnea. It is an assessment of sleepiness of the person because of sleep deprivation as a result of multiple choking episodes or multiple arousals that happen during the sleep apnea. So one of the most commonest questionnaire that is used is a Berlin's questionnaire. Uh, it is developed as early as in 1999. It is usually in the primary care setting where it is intended to be used. So the first section is about snoring, having all these questions. The second section is about daytime fatigue and sleepiness, having all these questions. And the third section is about the medical history. So if two or more categories are positive, then the person is considered a high risk for OSA. So a Berlin has the highest sensitivity and can detect OSA at a cutoff of more than 30. But when you reduce the AHI of less than 5, its sensitivity and specificity drops down. Of course, in the community, we are not really looking at somebody with a AHI of 5. We are looking at a moderate to severe OSA where it does serve the purpose. So this is an Epworth Sleepiness Score. We are all very familiar with it. And if you see, the score ranges from 0 to 24, an 8-item questionnaire which measures the daytime sleepiness of the individual, and a score more than 11 indicates sleepiness. And the highest ESS sensitivity is observed at AHI of more than 30 events. Again, it is more for a moderate to severe OSA only. It may fail to detect people who don't have sleepiness. So we are all very familiar with this concept of non-sleepy OSA. So we have to be aware that a person who's not sleeping doesn't mean doesn't have obstructive sleep apnea. Especially this is true in people who use their cognitive function for their day-to-day activities, because they are aware that they'll fall asleep given a particular task. They may not do that task or find ways of staying awake. And more common in children. So the most commonest used questionnaire is the stop bank questionnaire, which has these questions. And if more than 2 questions are positive in the stop, then it suggests a high risk for obstructive sleep apnea. And bank is the surrounding things. If any one point is assigned, if it is positive, anything it's more than 3 is considered a high risk for obstructive sleep apnea. So what is the clinical value of these questionnaires? So like I told you before, at a very low cutoff, their sensitivity and specificity is very low. But as the AHI goes up or the clinical probability of OSA is high, these questionnaires tend to do well. So there is this Stanford Sleepiness Questionnaire, which helps us assess what happens after a certain intervention is done. But then there can be a recall bias as well. So according to the American Association of Sleep Medicine, the clinical tools, questionnaires, and predictor algorithms are not supposed to be used to diagnose a patient with OSA. You have to supplement with a polysomnography. These are tools to screen a patient and not to diagnose obstructive sleep apnea. So what then we are forced to do a sleep study. So what is a sleep study? A sleep study is you're observing the patient during the whole night. So a level 1 sleep study is done in the lab with all these channels. So the channels include brain, EG, EOG, the chin, the breathing channels, and chest movements, pulse oximetry, the leg ENMG, and a video and an audio, and is observed by a sleep tech who's sitting and seeing the whole proceedings. So this is a level 1 polysomnography which is done in lab and is attended by the sleep tech the whole night. Then comes the level 2 polysomnography. Nearly the same channels are transported to the patient's home. So there are EEG leads which can be worn like a helmet, and these other things can be put on, and the patient is given instruction how to take care of it, and is an unattended home sleep study which will give you similar results as a level 1 sleep study. So here you will know from the EEG and EOG whether the patient has slept. EMG and other changes can also be picked up. Central apneas can be picked up. So it is as good as a level 1 PSG, but it is unattended. That has its own problems. Level 3 is predominantly respiratory channels are there. So you have an oximetry, you have chest movements, abdominal movements, and we look at only the apneas and hypoxias are picked up. But the data that we get is a whole night's events that have happened. So we don't know from the time patient is put on to the time that patient takes off these sensors, whether he has slept or he has been sitting and walking around, we would never know. So that's the fallacy of the level 3 sleep study. So it doesn't tell us the total sleep time, whereas level 2 and level 1 tells us about the total sleep time. And the level 4 is just the oximetry, which tells us overnight how many times patient has desaturated. So what are the ASM recommendations for the levels of sleep study? So does every patient need a level 1 sleep study? Ideally, yes. In a real world scenario, we would all want a level 1 sleep study where one night study will tell us everything that's happening, and answer all our questions. But it is not practical to, given the workload, it may not be practical. So in an uncomplicated patient, we can do a home sleep apnea testing. So what does an uncomplicated adult patient mean? An uncomplicated patient who has very classical symptoms and signs of OSA. So a single night, if it is negative, we may have to repeat it again if the diagnosis of OSA is strong. So uncomplicated patient means patient doesn't have any increased risk of having other sleep related breathing disorders like central sleep apnea, hypoventilation, or a sleep related hypoxia. So we have to that's why a detailed history is very important before we subject a person to sleep test. Just because a person is snoring and a person is not able to sleep, ordering a sleep test is not a good idea. Significant cardiopulmonary diseases like respiratory muscle weakness due to neuromuscular disorders, stroke, chronic opiate medication use is all a contraindication. And a concern for non-respiratory sleep disorder like a central hypersomnolence, parasomnia, sleep-related movement disorders, or a severe insomnia. Like I told you, if you do a level 3 study in a patient with severe insomnia, he may be awake the whole night and might be holding his breath 100 times an hour. So you will pick up all those things as apneas. They may not be related with any hypoxias, and then you will label the person probably as sleep apnea, but patient hasn't slept at all. So that's the caveat. And if the patient's environment and the personal factors prelude to the use of a home sleep study. So who's the ideal patient? We know whom we should not do. In whom should we do? A patient who's a moderate to severe risk of OSA, as indicated by this history of habitual snoring, witnessed apnea, gasping or choking, a diagnosed hypertension, and what is it adequate and doesn't have any of the other contraindications. What is an adequate equipment for a home sleep study? It should have at least a nasal pressure transducer, chest and abdominal respiratory inductance plethysmography, and an oximetry. So these are the minimum. But having a EEG channel, EOG channel adds on to the uh, diagnostic accuracy and gives us the total sleep time of the patient. And a technically adequate, when will you call a sleep study which comes out of the lab as technically adequate? At least 4 hours of adequate oximetry and flow data should be obtained, and or at least 4 hours the patient should have slept. So that is the adequate test. So can we do a split night study? Yes, a split night is the other option. You can do it in lab if a moderate to severe OSA is observed during the first 2 hours of the recording time, and at least 3 hours are available for CPAP. So suppose a person has a very high probability and the technician who's doing it is smart enough not to is to take the call that within the first 2 hours, if the patient has say 50 apneic events per hour or 100 apneic events per hour, then it is wise to convert. What do you gain by observing it overnight, provided the patient has no other comorbidities? Otherwise, the time that is available for titration sometimes may not be enough. You need 3 hours for a CPAP titration. And if the patient has other comorbidities, then if you are looking at converting it from CPAP to BiPAP, you will not have time for an adequate titration. Hence, in a coexistent disease, we are not supposed to do a split night study, but I alone, standalone OSA CPAP titration can be done on the same night of the sleep study. So the next thing we have looked at polysomnography. We have to schedule polysomnography of one sort or the other, the different levels we've seen. The next thing is a sleep diary, assessment of sleep. Basically, it looks something like this. There are many sleep diaries available. None of them are standardized, as we don't have a clear-cut guideline as to which sleep diary to be used. So, what does a sleep diary tell us? Sleep diary is used to understand the patient's sleep-wake cycle and understand how his schedule is. Basically, as simple as that. So a detailed analysis of his sleep-wake schedule. What is actigraphy? Actigraphy is a small watch like this, which can tell us about which senses the patient's movements. If you put it in a very simple way, it's an accelerometry based technology that it picks up the patient's movements. So if you see an actigraphy result of 2 weeks, a patient wears a watch like this, and you see the result like this versus a result like this. So these are areas of sleep. The blue are sleep and the irregular lines are wake. So compare the first one with the second one. So very graphically, we can see that this person has a regular sleep-wake cycle. This person over 24 hours, over the period of 2 weeks, sleeps when he wants, wakes up when he wants, and the sleep-wake cycle is a big mess. So it can help us understand the habitual sleep-wake patterns, evaluate circadian sleep-wake rhythm disorders, idiopathic hypersomnia, or behaviorally induced insufficient sleep. So some of them, a person who might be sleeping like this might feel that he's not sleeping well and might complain that I don't sleep at all. This will be a proof to him that you are sleeping well. And the cause, you'll have to evaluate some other cause for excessive daytime sleepiness. And this can, if a teenager comes with a sleep wake cycle like this, so you can make them understand that discussions about sleep, the quality, the quantity, and the schedule, all that can be explained by an actigraphy. So there are other sleep monitoring devices also. So you can use the actigraphy at home. You can have wearables like band or finger ring and mattresses that are now coming up in the market, which are being used for assessment of sleep. And they're not, we are yet to see medical grade devices for this available, but devices are available in the market. So coming to wearables, they basically are accelerometers like the actigraphy or a photoplethysmography in sleep tracker, and they're not validated for medical use. Heart rate and heart rate variability are calculated, but their application in sleep assessment, that is what I'm trying to say, is in clinical sleep medicine, is still in area of research. And the accuracy to evaluate sleep stages and all the research is going on, but still it is still in a nascent stage, and the market is still a pretty good market for all these devices. You have Apple watches and Android watches available which tell us all this, but we don't know how accurate they are. So summing up all that I've told together, you have a clinical suspicion of OSA. So then you ask whether the patient has signs and symptoms that suggest moderate to severe OSA. If this is there, then we ask the next question: is the patient suitable for a home sleep study or definitely an in lab? And if home sleep study, it should be level 1 or level 2. So these are the questions that we have to ask. Make sure there are no other comorbid conditions that can explain his sleepiness or his sleep related complaints. Snoring might be there. Along with that, patient might be snoring because of chronic opioid abuse or a stroke or a sleep related hypoventilation, COPD, chronic respiratory failure. All these are a big no for a home sleep study. We have to do a in lab sleep study for them. So if these anything is yes for this, a home sleep study is a contraindication. We have to perform an in lab sleep study. And if these things are not there, and depending on the patient preference and your preference, we can perform a home sleep study. But the caveat is that it has to be manually scored, because many a times what happens, a level 3 device which is auto scored has a lot of errors. So we have to manually score it, and if the diagnosis is positive, then patient gets further treatment, or else we have to look for other explanations for his sleep related complaints. So, summing up all my whole presentation, a sleep questionnaire advantage is it's brief and it has low patient burden, but disadvantage, it's very subjective. Like for a driver who wants a license to be, for him to get the license, will never accept daytime sleepiness. And there are some who are not at all sleepy OSA, and there are some who don't even realize that they are sleepy. And sleep is a very for some people, daytime sleeping and napping is an accepted routine in the daytime, so they don't complain of sleepiness at all. And its validity against the PSG is limited. And polysomnography is the gold standard, but the cost and the time consuming. So then we have the home sleep studies available. Sleep diaries, we thought it's the helps us understand the sleep wake cycle of the patient. Similarly, if you put the sleep diary into a device which records it, actigraphy records it objectively. So these are my references. So from the first sleep lab, the huge computers and data coming out, to a sleep physician sitting and scoring the sleep or observing the sleep study being done, we've come to wearables as small as a finger ring or stuck to the finger oximeter, to a portable sleep study, to a ring that can be worn for a complete sleep study. This we are reaching that stage. Thank you. Now I hand over the podium to Dr. Raja.
Thank you very much, Priya. Absolutely brilliant talk. I love the precision with which you covered the entire length and breadth of sleep diagnostics, and the way you covered the SM guidelines was absolutely brilliant. I love the flow diagram which you showed, and maybe we'll come back to that later on because I think that summed up your
That's it.
talk beautifully. Yeah, so we'll do that at some point. We've got our entire panel here, and I'll come to introductions in a moment. If you could share slides for the introduction, the Blueberry Events team, please. So we've got 2,300 logins nearly. So that's the number of people who were listening into you, Priya, just when you finished. And hopefully we'll have the entire team with us as we go forward. So like I said, I've got a elite panel with me today. You've heard and seen Dr. Priya Ramchandran. The second person on my panel is none other than Dr. Pratim Bose. Parthoda, as I call him, is a very revered senior who is the founder president of SARS Foundations, a senior consultant and faculty at the National Heart Institute. Pulmonary critical care, sleep medicine, and rehab are his fortes. He's attached to many other corporate hospitals, and his area of interest, his area of expertise, research is airways disease and sleep. If you look at his fellowships, he's done fellowships in sleep medicine from all over the world. So he's done it from Australia, Ireland. He's a fellow of Indian Sleep Disorder Association, the ISDA from India. And if I read through all his recognition and his books contributions, it will be most of our webinar today. So the country knows him, all of you know him. So Parthoda, warm welcome from my side to the Indian Chest Society module on sleep medicine. The next person is a young colleague, a very bright young colleague of mine, Dr. Neil Thakkar. Dr. Neil Thakkar is from Baroda, and he's done a lot in the way of academics, in the way of inspiring a lot of his contemporaries, his juniors in the area of respiratory medicine. He continues to be one of the leaders in that particular generation. His present position is a consultant pulmonary and critical care physician. He's from the Pulse Clinic and Sterling Hospitals in Vadodara. Multiple presentations, so 40 presentations, multiple publications, and see where the publications is from. He's published in the European Respiratory Journal, in Chest. That shows the depth and interest in academics that he has. Members and fellows of multiple society, and again a very long list of awards already. I'm sure there are many in the offing, and he's invited as author Point of Care Solutions by Elsevier for pulmonary and critical care. So that's Dr. Neil Thakkar. Like I said, you will hear through the course of the meeting today, if you've not done it already, the way he thinks, the way he processes things. He's also done a small survey, which I'll ask him to talk about in a moment, for this particular meeting. And I'll ask him to talk a little bit about the experience that he's gathered from that survey in a bit. So that's Dr. Neil Thakkar. The next person on my panel is Dr. Srima PB. Srima is again a young, bright pulmonologist who is an associate professor, Department of Pulmonary Medicine, AIIMS, Nagpur. She's done her MD in internal medicine from All India Institute of Medical Sciences, New Delhi, and then done a DM in pulmonary critical care and sleep medicine, again from AIIMS, New Delhi. She's done her EDRM. Again, like I said, she's a youngster with 20 publications in index journals, reviewer in multiple international journals, and she has, in her areas of interest, a prominent place. The reason why she's with us today, a prominent place looking at sleep disordered breathing. So very warm welcome to Shrima. I'm especially looking forward to interacting with Shrima because she's one person I've not really interacted with in meetings before as a colleague. So really look forward to her inputs today. The next person on our panel today is Dr. Mohana Krishnan J. So Mohana is a consultant pulmonologist and sleep specialist, Apollo Hospitals, Vanagram, Chennai. He's done his MBBS from the government Vellore Medical College, diploma in TB and thoracic diseases from MMC, Chennai, his DNB from Ruby Hall Clinic in Pune. He's a member of the Royal College of Physicians. He's a European diploma. And then he's done a fellowship in sleep medicine, the IDSA fellowship, much like Parthoda has. And again, to have so many accolades, so many feathers in his cap at the age that he is at, I think speaks volumes of his interest, his academic enthusiasm in the specialty. So a very welcome, warm welcome to all my panelists and colleagues today. If you can unshare slides so that I can see everyone better, please. Thank you. So we'll start off without much ado. I'll start off with you, Parthuda. Parthuda, we'll start off a little bit about clinically suspecting someone. So you got a patient who walks into your clinic. There can be two scenarios. One, they come in with symptoms reminiscent of OSA, or they come in with a different problem, and you suspect that the patient might have concomitant obstructive sleep apnea. Can you tell us a little bit about the two scenarios? What makes you suspect OSA so that you send them over for diagnostics, which Dr. Priya Ramchandran has very beautifully described just now? Parthuda.
Thank you, Raja, as I call him Raja. Thank you for giving an opportunity to interact with this august panelist. And thank you, Priya, for what a crisp and eloquent presentation. Yes, Raja, what you asked is very pertinent. Let me tell you, before answering your questions, I don't call it just a sleep apnea or a syndrome. It's an umbrella term. Sleep disorder breathing moves from a simple asymptomatic snoring to obesity, hyperventilation to overlap syndrome. It's a huge range of disorders. So you're giving me two scenarios. The most important thing you have to understand as a clinician is that is your intuition, is your suspicion, your experience, because what's more important that every phenotype of sleep disorder has a different kind of genotype. So you have to keep those phenotype and genotypes in mind. So I think the most important thing is that your suspicion, as you rightly said, in both the situations. I think the spotter here is your clinical look. If you find somebody with clinically the sleep disorder breathing is a spotter in moderate to severe, they are short neck, they have, and if you look into their oral cavity, they have what we call we normally do the Malapatti scoring. They usually have a high grade of Malapatti scoring. And the typical look of sleep, and if you ask him this very pertinent question, do they snore, and anybody has witnessed apnea, does he feel sluggish or fatigued in the day? I think just a look of it, looking into the oral cavity, then going back to the questions gives you a spotter diagnosis. And as you rightly said that, yes, there are one situation, you don't have comorbidity, you just is your index of suspicion, looking into the next circumstances in an oral cavity, and you think of sleep disorders, then probably you go for other typical questionnaires and testings. But when you have the comorbidity, as you rightly say, especially the cardiovascular and comorbidity, all the more reasons your suspicions become more pertinent. So when you have comorbidity and this kind of phenotypic look, which I told you, a classical look of a sleep apnea, looking a little groggy with a cluttered upper pharyngeal, so it becomes more relevant to go for a kind of you can say clinically that he's a sleep apnea. So sure. I think if you add one more word here, the classical symptoms, usually this group of patients, whether you catch the category A or B, what I call is unrefreshed sleep. I'm not saying sluggishness. Many times fatigue and sluggishness may be an overlap term. What they normally talk about is they are not very happy with their sleep. It's an unrefreshing sleep is the thing which catapults into those kind of intuitive thinking.
Sure. Yeah. But very, very nicely described. So you heard what Dr. Parthobos said. So of course, there'll be your classic phenotype of patients who come with all the daytime features of obstructive sleep apnea. But then you have others who come to you with a problem which is different, but a load of comorbidities which are difficult to control with standard medications. And you think of sleep apnea and ask leading questions, which might give you the answer in those cases. I think those are the classic phenotypes. There's a question in the question box, Parthoda. I'll run this through past you before I move forward, because it's an line with what we are discussing. So Dr. Sameer Ahmed, who is a young pulmonologist from Telangana and Hyderabad, asks about snoring without excessive daytime sleepiness. Should we go for a PSG? And this is the reason I'm asking this question now is you rightly said this is not just about daytime sleepiness. It's about sluggishness. It's about tiredness. It's about lethargy. It's about memory impairment, lack of concentration. So all of those questions need to be asked rather than the one classic question, are you sleepy? Your response, Parthuda.
Dr. Raja, even with my so many years of experience, I said, moment somebody talks about snoring, it should start thinking that you probably pick them early. It's something like you pick a COPD early in the ladder so that you can treat them early and make them.
Sure.
So even an asymptomatic snorer should be evaluated, and if not, I'm not being classical. You should ask the attendant to send a small video to see the sleep pattern and all those things. And of course, there's questionnaires and other things probably help you to understand.
Yeah.
But I think
Sure.
all asymptomatic snorers should be evaluated.
Yeah, brilliant. Thank you. Thank you, Parthuda. We'll move on. And let me move on to Dr. Neil Thakkar. Neil, I'll ask you about the stop bank questionnaire first. What is the importance of stop bank? Do you do it always in your clinical practice when you see someone with suspected sleep apnea? And how does doing the stop bank questionnaire help you over and above the various symptom-related features that Dr. Partho Bose has just spoken about?
Thank you so much, sir. Again, continuing with just the last question that we had got, that if somebody just has a snoring episode without daytime sleepiness. So in continuing with that question for this, that if there is somebody who just has snoring, then the stop bank questionnaire again becomes very important in assessing the pretest probability of sleep apnea. Madam has already described all the components, predominantly snoring, tiredness, observed apneas, the blood pressure, which is uncontrolled. Now, again, blood pressure is any patient who is hypertensive, that is in the stop bank, yes or no, will be there. However, even if a patient is hypertensive but on multiple drugs and the pressure is not getting controlled despite checking all metabolic parameters, so that would also become somebody who will have a high probability. Higher BMI, age more than 50, neck circumference, and gender. So all of these parameters in my clinical practice, suppose a patient is being checked outside when he comes to the OPD, the weight is checked of the patient. If I'm suspecting that this patient has a relatively high body mass index, I would make sure that we have a printed stop bank questionnaires in our OPD. So we would get the patient to fill that based on the symptoms as well as our assessment. And it has a very good sensitivity for moderate to severe obstructive sleep apnea for diagnosis. And especially now we also have the enhanced stop bank questionnaire. So one was the older one where it
Sure.
divided into whether low risk, intermediate risk, or high risk. But what they found was that when we say 0 to 2, 3 to 4, or more than 5, but each of the questions does not have equivalent predictive value. So the enhanced stop bank questionnaire was developed first by stop bank was by Chung, and later on it was developed in such a way that now the male gender, a higher BMI, and a higher neck circumference, these three had relatively more predictive value. So only stop, two or more questions of stop if they are positive, and even one, either male gender, a higher BMI, or neck circumference, then it again shifts the patient towards a higher probability of obstructive sleep apnea. Now, related to this, I had done a study at our center in around 2017, where we compared the Epworth sleepiness score, the stop bank questionnaire, and utilizing that and a level 3 study, and comparing, because in the Indian constraints, we'll be coming to various sleep studies later. But in this discussion, that if we use a combination of a questionnaire and a screening device, especially when there are cost constraints to the patient, that still gives us an answer in a lot of these cases. And it did show, especially with regards to the positive predictive value, in our particular study was close to 88.2%, while the negative predictive value was around 62.5%. So still, and amongst the two, we compared the Epworth sleepiness scale also. In our particular study, we found that particular ESS is a better screening parameter because of the sensitivity and the negative predictive value. But stop bang remains a very strong tool, especially for pre-test probability as well as pre-operative probability of obstructive sleep apnea. I hope that answers the question.
That answers my question very comprehensively, Neil. So very, very important points you made. I won't add to it because you've not left anything for me to add. But just to say that along with the stop bang, we are about to publish the results of the Indian Sleep Registry, which was done a few years ago now, which we have not managed to publish. One of the things we found was the abdominal circumference also has quite significant contribution if you add that over and above the stop bang in increasing the sensitivity, as you put it, Neil. And I think Dr. Parthobos also spoke about how crowded the back of the throat, the oropharynx is, the Malampati score. So that's another thing that probably needs to be added to the mix. There's an interesting question, Neil, and again, I'll run this past you before we move on to Dr. Srima. It's Dr. Swati from Puducherry who asks, stop bang is for all OSA patients or only for preoperative suspected OSA patients? I think you heard what Neil has just said, Swati, about the fact that it's a very good predictor in moderate and severe. And mind you, he's left out mild, which is the category in which stop bang is not so specific, even as per the Sleep India registry. But a comment about pre-op, do you think stop bang plus Malampati is the most sensitive there, Neil?
Definitely, sir. So pre-operative, definitely. But again, if the question is that compared, like it will still be a very good screening tool in your OPDs, even in your health checkup. So in our hospital, we have even the health checkup physicians are sensitized that if a patient has a relatively high BMI, they have a stop bang questionnaire in the health checkup also, so that patients at a primary level can be assessed if they have a relatively higher probability of sleep apnea. And as you mentioned, waist circumference, one more thing which was studied in a meta-analysis in 2017 was the serum bicarbonate levels with the stop bang questionnaire. So that was also one more parameter. If a patient has an elevated bicarbonate level with a higher stop bang questionnaire, that also raises the pretest probability of sleep apnea. And it's a very good pre-operative tool, especially in surgeries. Yes.
Yeah. So I think Neil makes a very important point there. So for the pre-op patient, along with the questionnaires that we are speaking about, along with the Malampati, doing an arterial blood gas in these patients is of great value in screening, and looking at the bicarb is something which is important, like he said. Let me go forward and speak to Dr. Srima. Srima, I'm getting your name right. That's how you pronounce your name, right? Srima is right?
So it's called Shaima, but it's
Shaima.
okay.
No, I'll correct myself. So apologies again, Shaima. So that's why, because Shima is a very Bengali name, so when a place I hail from, so it's so that's why I got it wrong. But apologies, I'll make sure I don't pronounce your name wrong again.
No, it's
so
okay,
Shaima, the Epworth sleepiness score is something that Neil has alluded to already. So again, is that something you would routinely do? Epworth, as we know, covers a lot of the symptoms that Dr. Parthobos spoke about when he initially spoke about symptoms. Do you think having a questionnaire like ESS adds to just asking questions like you would do in a sleep history? Do you do it routinely? And if you do it, what extra does it contribute to your clinical practice in taking a proper history for sleep apnea? Shaima.
Right. So basically, what we have to understand is that it is only a sleepiness scale. It is not for diagnosis of OSA, but you get a better result than asking the patient a blank question. So like if you ask, "Are you feeling sleepy?" you would not get a proper answer, especially true in case of female patients, which I've noticed. So when you put it as questions with answers, it gives a better idea, though it is still subjective because it's a questionnaire, but it is a good method to quantify the sleepiness.
Sure.
But still, we have to understand that we do have non-sleepy OSA, and we also have patients who might be sleepy, and it does give a number, but it does not mean that the patient has OSA. It only shows that your patient is sleepy, and it is up to you as a clinician to find out what is the reason for it. So basically,
Sure.
it's not for diagnosis of OSA, but it helps in quantifying sleepiness. And another use is that if a patient does have a high ESS score post treatment, you can use it to, subjectively give a number that your sleepiness has reduced. So that proves to your patient also that okay, that is also getting better with treatment.
Yeah.
So in patients do have sleepiness, it helps you to quantitatively put a number to their level of sleepiness, but it
Sure.
is not for diagnosis of OSA.
Yeah, great. So,
Right.
Shaima, like you said, valid point that if you have a high effort sleepiness score and if you start treating them after an interval of, say, 3 months, you would repeat the score and see how much it gets corrected. What
Right.
about the converse? Suppose you have an effort sleepiness score of, say, 7,
Right.
6. How
Mhm.
good is that in excluding sleep apnea? Would a low effort sleepiness score, if you keep everything aside, that alone, would that prevent you from going for a polysomnography in these patients? What is the negative predictive value of doing an ESS and having a low score from it?
That's a very good question. So, exactly. So, even if a patient is not sleepy, does not mean that you do not evaluate for OSA. If the patient does have the other risk factors, like if it's like already an obese patient with a greater malumpati, and as I briefly mentioned, female patients, you get more of non-sleepy OSA in females. So, all that. So ESS does not exclude you from doing a sleep study if you clinically otherwise have enough features to suspect OSA, like in a young hypertensive, an obese patient,
Oh,
or an atrial fibrillation, or pulmonary hypertension, all these, or even other sleep complaints, or if they are snoring but not they do not have a
oh,
higher ESS score, you do not decide against doing a sleep study.
yeah,
So it is just one parameter which you use in addition to your rest of the clinical
sure.
evaluation.
Yeah. So that's an important message for everyone in the audience who's listening to us. While the Epworth sleepiness score is useful, especially when it's high, a low ESS in the presence of comorbidities, in the presence of other features which are not included within the Epworth sleepiness score, it mandates that you investigate further for sleep apnea. And ESS being low does not exclude the diagnosis of sleep apnea. And I think that's a important message that needs to be conveyed about the Epworth sleepiness score. Thanks, Shaima. Let me come to Dr. Mohan. Mohan, it's okay if I call you Mohan, right?
Yeah, yes, sir.
Yeah, okay. So, Mohan, there's a lot of questions in the question box. There's a lot of interest about using scores and scales. So two of the scales that we know of are the Pittsburgh and the Karolinska. There's other less commonly used scales. Um, how useful do you think these are? And I'll add a little bit from the question box about, do you think these are more useful in a tertiary care center? Or do you think this is more important in a primary healthcare screening center with less amenities? Do you think it needs to be done in both? How do you position these scoring scales that we have? And do you use them in your clinical practice for sleep medicine?
Yeah.
Mohan.
So as you mentioned, there are multiple scales available. Most of them are subjective. So it's definitely a subjective experience of the patient, whether they're tending to fall asleep or they are not getting sleep in the night or excessive daytime sleepiness. So most of them being subjective, as you already mentioned about the Pittsburgh scale and this Karolinska scales. There are many simple scales like mini sleep questionnaires where we can go for about identifying patients with insomnias or hypersomnolence. These scales are very easy to be used or easy to be asked in all subset of populations. So right from the primary level to the tertiary care level. But as you already mentioned, the amount of involvement or the evidence based on the scores like stop bank scores or upper sleepiness scale, these are less venture. The as I in my routine practice, I don't do often. Once I do upon the stop bank and the ESS, maybe in the follow-up or in some patient, I do use this Pittsburgh scales where we can assess the sleep quality in the last 1 month in in the person. So the person will be more easy enough for them to remember or to identify whether the sleep is troubled, not only for short time or for the last 1 month. So this gives us an idea for the treating physician as well as for the patient to understand they're really suffering from a sleep disorder, which is not transient or just temporary for a few weeks. It's been there for many months. In those ways, these simple scales like Pittsburgh scales and mini sleep questionnaires are do helpful in real scenarios. But once we charge them or once we focus them on the stop bank and regular ESS score, we get most of the patients population in those subset itself. That's what I feel, sir. So in my regular practice, once I finish this ESS and stop bank, I do use these small scales, rarely, especially Pittsburgh, which I do prefer to assess the monthly performance of the patient.
Okay. So what you're saying, Mohan, is that you would use them in follow-up. You would make sure that the symptoms are long-term. So looking at temporal association of symptoms rather than cross-sectional, doing it only once over and above doing things like the ESS and the stop bank doesn't add a lot of value, but it's doing it monthly to make sure that the symptoms are persistent rather than being transient where it's more useful. Is that sort of fair
Yes,
to say, Mohan?
it's a kind of a follow-up scale also. That's what I
Okay.
feel.
And I'll just add another question, which is there in the question box, Mohan. Do you think all of us on this platform work in tertiary care centers, in big centers? There's lots of amenities. You've got lots of backup. We've got staff who help in addressing questionnaires. Do you think in sort of secondary care, in areas where there's less amenities, less facilities available, do you think so? Places where you can only do a sleep study, which is significantly rudimentary. So, stage 3 sleep study, for instance, would you think that these scores have greater value, or do you think it's exactly the way you've put it, looking at temporal correlation, long-term follow-up of patients, that these scores are useful even in that setup?
No, as Dr. Priya has mentioned at talk, the scores have got definitely a good amount of correlation in assessing the sleep apnea subset of population. In Tier 1 and Tier 2, Tier 3 cities where the opportunities are very less for the sleep labs, scoring is vital, as well as these scales can be addressed correlating with the other parameters, sir.
Sure, sure. Great, thank you. Let me go to Priya. You've mentioned Dr. Priya Ramchandran. So let me go to Dr. Priya Ramchandran. Priya, are you there? Okay. So while I'm waiting for Priya to switch the
I'm
video,
there.
you're there. Okay. All right, Priya. Priya, I've got two questions for you. I'll take the question about secondary care and looking at questionnaires. I know you spoke about this in your talk and you underlined the fact that these are useful. I wonder how useful you feel that these are in tertiary versus secondary care facilities where there's less infrastructure available. That was the first question. And the other question I wanted to ask you was some carry home messages. You spoke about this in some detail in your talk, but a carry home message about positioning PSG and the different levels that you spoke about in your talk. So those were the two things I wanted to ask you.
Yeah. So the questions are like asking the patient a detailed history.
Sure.
In a very systematic manner, where you put it down and convey it to somebody else also that you have asked these questions. So it does that much. So it's exactly like a history that we take in any other disease process. And probably some of them give you a number on top of it. So how good it is, there have been some questions in the chat box asking about the translations, different languages. Yeah, from the study point of view, you need a validated process. But for a general clinical practice, it's enough to, if you understand what you're asking and the patient understands what you're asking and you understand what the patient is telling you. Simple. So sleep is in the community still not felt need, like people don't complain so much about OSA kind of things. So that being the case, we are here with a few problems, like in a tertiary care center, you have everything, you do everything. In a step down, say in a district hospital or some other place, you might be having resource constraints, personal constraints. So then questionnaire assess the clinical probability, the implications of the diagnosis on the patient, and whether the patient can take the treatment. See, we are talking about subsidizing the sleep study, or I don't have the facility for the sleep study. Many a times we fail to ask the patient, do you have electricity in your house?
Sure.
As simple as that.
Yeah.
So we have to take the whole thing into consideration when we ask for a sleep study. And of course, we can always tell them to do lifestyle modifications, upper airway exercise, weight loss. Those things are definitely doable for everybody. And all these small things like the neck circumference, the crowded airways, and comorbidities, all this should add on and help us make a diagnosis
Yeah.
with the sleep study. Level
Sure.
1, ideal. If we don't have, level 3 at least.
Yeah. So quickly, Priya, the reason Mohan, I think, gave a very valid answer to the question. The reason I bounced it past you is a question that's sort of repetitive, but I'll just mention one in in the chat box here, which is, can we diagnose OSA without polysomnography? And I think people are alluding to doing a detailed examination, asking questionnaires, and just a message from our side, from your side, that polysomnography is still the sort of a golden rule for the diagnosis of sleep apnea. It's not that any of these questionnaires can replace it, it supplements and leads you to a polysomnography rather than being a replacement for polysomnography. So, is that a message that you would agree with, Priya?
Definitely, Dr. Rajadhar. It's like not doing a sputum analysis for TB. X-ray is suggestive, you go ahead, treat. You're 50% right, 50% wrong. Here you may be 30% right, 60% wrong also sometimes. So you'll have to take that. And if the person can't travel to get a sleep study done, may not be compliant with the CPAP also.
Sure. Okay. Grand. And quickly, sort of level 1, level 2, level 3, and level 4, Priya, how do you position these? So, one line message for each of these. Do you think there's any relevance for a level 3 and a level 4? Or do you think you would stick to a level 1 and a level 2?
See, if you are in push to the corner and you don't have any facility, patient definitely needs a diagnosis. Even a level 4, if you can sit with the patient and get a overnight oximetry which shows recurrent desaturations with snoring and apneas which you have witnessed, diagnosis established. But that is very labor intensive, practically impossible. So a level 3, if you have no other comorbidities, plain and simple sleep apnea, level 3 is good enough. And your clinical suspicion is very high, like all your scores are very high, then your AHI will be more than 30. You are on the right track. But if the patient has any comorbidities, a level 1 is better. A level 2, substitute for level 1.
Yeah. So I think the clear message from Dr. Priya Ramchandran here is that under ideal circumstances, you would always do a level 1 or at least a level 2. A level 3 or a level 4 can be done in areas where you don't have access. And the higher the pretest probability of sleep apnea, based on the questionnaires, based on examining the patient, the history, etc., the greater the chances that you could get away with a level 3. I think that's the message that we are trying to give here. I can see Neil's hand. Yes, Neil, a quick comment, please.
Just one comment here, that we discussed about level 4 studies in this discussion. So just besides it will give definitely where resources are scarce and where we are, even level 3, level 4 where we are using. There is a medical legal aspect also now to this, that I won't name the companies or whatever, but there are some companies where in USA and otherwise there was a litigation and other things with regards to the use of CPAP machines, where the foam particles later on led to certain other problems, which were then there was a recall and then things were settled. So in this case scenario, medico legally, for at least the purpose of, we have guidelines to guide us definitely, but if suppose a patient in a setting where you have like if a patient has a level 4 or hypoxic, has a questionnaire positive, you're treating that patient with a CPAP machine, it is like we have with drugs or with any surgery or otherwise, that to have a documented ideal level 1 study or at least a level 3 study in such cases kind of gives a strong ancillary support for your diagnosis therapy, as well as for touchwood in India there is no strong litigation with regards to sleep apnea till now, but
Sure.
to establish a diagnosis medico legally, that is important. Just one comment there.
Yeah, no, absolutely, Neil. I think you make a valid point. And I think what we are all trying to stress on this board is if you had an option, you would go for a level 1 or at least a level 2. The level 3 and the level 4 are backed with far lesser evidence, should be done where you're really pushed against the wall and where the pretest probability is high. And even if you do give a machine to a patient based on a level 4 or a level 3 study, you would want to watch them closely with things that you would miss out on a level 3 and a level 4 study. So complex sleep apnea, for instance, with the CPAP, you probably central sleep apnea, mixed sleep apneas, you would probably do more harm than good by just giving these patients a CPAP. So valid point, I think, that Neil makes here. Let me move on. We've got lots of questions and not a lot of time left. So let me come to Parthoda next up, Dr. Partho Bose. So 3 terms that I want to come to you with. One is apnea, the other is hypoapnea, and the third is RERA or respiratory effort related arousal. So if you can give our audience clear messages as to how these terms are different and how they're important in the terms of doing a sleep study. Dr. Partho Bose.
These are the different forms of respiratory events which happen during sleep disorder breathing. So I'll go by hypopnea first because that's more important. Hypopnea is there has to be the respiratory events has to be 30% down and associated with there are 2 criteria. There should be a 4% drop in oxygenation saturation. ASM says that even a 3% drop in oxygenation saturation with arousal, that also can be taken. There are two criteria. 30% drop in the events and with a 4% drop, or 3% drop in saturation with arousal. This is hypopnea. Why I'm saying the hypopneas are very important. Many times what happens, if you don't score the partial closures accurately, you can inadequately titrated CPAP can convert apneas into hypopneas. The people go into more complications. So hypopnea is very important. And apnea, we know, is total stoppage of respiration. Again, we have to document position characterized by paradoxical movements, arousals, and the drop in oxygenations, the same standards. Respiratory effort related arousal, that means it has to be snort associated with, they don't go into apneas or hypopneas, they go into change in the arousal, change in the EG parameters of different activities. They can go alpha, beta, they can go back without any REM activities there. So this is what we call the respiratory arousal index, and to assess the respiratory arousal, you need the level 1 study because you have to see the EEG activity, classified activities characterized by other factors also, the movements and the legs and everything. So in a nutshell, it's a combination of the partial closure of the upper airway and the total closure, and that decides the index score. Because this index is very important, and though at times it is, as we are talking about, if you're going into level 2, 3, and 4, sometimes 20 to 30% you can underscore the apnea index. So it's very important that because in the other studies in level 3, 4, and 2, we take the total sleep time because you don't have the EG activity. So because the denominator is a total sleep time, because actually you take you don't take into consideration the actual because it's a function of the EG activity. So many times you can give you a wrong scoring about 20 to 30%. So it's very important to understand the apnea, hypopnea, and also there is a combination called the central apnea. There is a total flow. There is no drive. There is no activity. This is all the 3 levels are straight. And the mix is a combination of the hypopneas, apneas. You can have the combination of all these things.
Sure.
So basically, to understand the different respiratory important index in sleep disorder breathing, the level 1 polysomnography is required. Otherwise, it's very difficult to understand.
Yeah. Yeah, so we all agree with that. So I think in an ideal circumstance, we would do a level 1 for most people. Partha, I've got another question for you. So in sleep physicians who score the sleep studies themselves often talk about the significance of having lots of hypoapneas and scoring them versus the machine calculating the number of hypoapneas. And there seems to be a discrepancy when you do that. So I noticed you started off with hypoapneas and you said that's more important. So if you see a study, you have an AHI which is say 30, and you find that all of them are 30 per hour, all of them are hypoapneas. Does that give you a lesser credibility as compared to having, say, about 50% apneas versus 50% hypoapneas when you're scoring them physically? Or do you think that does not really matter?
I'm telling you, I'm giving you a very practical aspect, which has been happening very rampant because of the cost constraint. Even in level 1, we are doing street studies.
Yeah.
Because normally, classically in my lab, I do 2-day studies, but many times it becomes really very expensive. Even many times in the classical, with the pretest variables are very high, when we have a high, we do the street study. Now, what happens? When you do the street study, and moment in the second half, when you connect the patient to CPAP or non-invasive device, the apneas get partially converted into hypopnea.
Yeah.
Because what is exactly apnea? It's a total it is a function of the neuropharyngeal coordination. It works on so many factors. Yeah. Your anatomical, your neurophysiological functions, what you call the tube law, and your level of how young is the patient, your drive and everything. So what I'm saying, why hypopnea is very important? Because clinically, sometimes I have seen in my clinic, in fact, I presented a paper, patient has come with a classical, OSA score of say 35 or 40. But once you have given them a partial treatment with CPAP, you have increased the score from 35 to 45 because you have converted apneas into hypopneas. This is called partial closures. You are not adequately titrate. Because most of these titration studies are done by auto CPAP. You don't manually treat or with esophageal manometry and other things. Normally in our sleep lab, we always do titration with EPAP. We use bilevels for titration. That's the one thing which I want to give a take-home message to the audience. Yeah. Never do a titration with a CPAP because the chances you convert apneas into hypopneas, and this can give you more problems. So it all depends how you're titrating. Whether you're doing 2-day sleep studies or you're doing street studies, whether using bilevel as a titration model or your CPAP as a titration, whether you're physically using or you're autopapy using. So I think that's why I'm saying the hypopnea is something very subjective. It can change. An apnea can be converted into an hypopnea by partially opening or partial arousal. So it's very important. And of course, there are so many other factors because if you don't have the right sleep time, you can underscore the apneas and hypopnea index.
So I think very, very important and pertinent points, Partha. Thank you very much. So I think the carry-home message for our audience today is, even with the same HI score, you might have two different severities because you have more hypopneas in one, more symptom burden, and more apneas in the other. And hence this distinction and looking at the sleep study yourself and scoring them properly is something which is very, very important, which often gets not underlined. People don't look at the sleep studies themselves and depend on the machine which scores the apneas and hypoapneas for you. So that's something that I wanted to stress on. I'll come to Neil next. So Neil, we've heard about apnea, hypoapnea, and RERA from Dr. Bose. I wanted to ask you about AHI, which we have spoken already, and about the respiratory disturbance index. So again, carry home messages, brief ones about AHI and RDI for our audience, please. Neil.
Sure. So AHI, I think sir has extensively described. The only difference with a respiratory disturbance index that it includes the RERA events, which again sir has described what actually RERA events are. But basically any breaths, more than 2 breaths that do not meet the criteria of apnea or hypopnea and lead to an arousal of sleep, which must have increased respiratory effort, a flattening of the airflow signal, snoring, or in cases you have a ETCO2 monitor, a rise in the ETCO monitor. So RERA is something which a lot of times increases the sensitivity. So as compared to apnea hypopnea index, RDI is more likely to pick up even milder sleep apneas because the sensitivity will go up because it is picking up the RERA events. From whatever the literature and the studies that have been done to compare the AHI and RDI, for RDI you do require an EEG monitoring because you need to know when is the patient getting the RERA events where the patient is getting aroused. And secondly, especially for home studies and in a scenario where the patient is not admitted, not in an observed environment, level 2 or level 3 sleep studies where the patient is at home, in such cases, the sensitivity of the RDI is much higher than compared to AHI as per the study published in the BMJ in 2015. Practically, it also, from the purpose of, again, in India, still we don't have strong insurance issues, but the International Classification of Sleep Disorders, or the ICSD-3, in that the definition of sleep apnea is through RDI. So an RDI of more than 5 with symptoms or RDI of more than 15, if the patient is asymptomatic, that is the definition of sleep apnea as per the ICSD. Also, for patients who are a lot of times diagnosed with a mild sleep apnea on AHI, can have a relatively higher RDI to classify them into moderate or severe. So relatively a higher classification may be there with the use of RDI. There was an older study which also showed a relation of RDI with cardiovascular mortality, that specifically with relation to sleep apnea. So these are just some short take-home messages, but RDI would have a higher sensitivity, cardiovascular relation, and classification of the sleep apnea may change using RDI.
So I'll pursue this a little further, Neil. Lovely answer, very detailed, very evidence-based. I'll ask you another question in response to what you've said. So, like you said, counting RERA events or doing an RDI increases your sensitivity. Now, you pick up more patients and you pick up more of the milder lot of patients. Now, imagine a scenario, Neil, where you have less comorbidities or no comorbidities, a reasonably symptomatic patient, but with a RERA which is raised, but with an AHI which is reasonably within normal limits or low. Do you think we end up treating more patients because the sensitivity increases and hence increase the actual burden on the state, on the economics, because you increase the numbers who require treatment by doing a RERA? Or do you think picking these up, treating them early, like Dr. Bose said a little while ago, is something which is a must for these patients? Neil.
Sir, practically, definitely, if you are saying that a mild sleep apnea is picked up with an RDI with a moderate, that RDI, then in such cases, definitely that patient will get early therapy eventually, and we have data. So cardiovascular mortality, that is why I mentioned that we have studies that, so suppose that same patient with a milder AHI develops a midnight hypoxic event and suddenly dies with an MI. So that hypoxic event could have been prevented if that patient was on therapy for OSA. So definitely with the economic burden, it has to be a holistic approach with the symptoms questionnaire, pretest probability and the symptoms. But the role of RDI as compared to AHI will practically help for the health outcomes. It is a better indicator. And even for insurance, like later on, they need to machine that.
So, Neil, you are obviously a very strong proponent of treating sleep apnea early, and I agree with you. Let's take another point of view. So, Parthoda, short answer. I see your hand raised. I also saw Shraima raising a hand, so I'll come to her in a moment. But Parthoda first. Parthoda.
One thing I just want to add here, if you go by purely RDI, that may not be the right way, because we classify sleep on the mild, moderate, and severe. But the biggest challenge in Indian scenario, because we are a young country, is the RERA. Because RERA, you don't get a very high RDI score. And that's why always proponent level 1 should be done. And who gets RERA? RERA are really younger people who have a sleep threshold is little low, so they get up early. So since it is a young country, we have average age is 29. RERA is a very serious form of sleep disorder. If you similarly extrapolated RERA people to another 10 years or so, there may be RDA may be 40, because by the time your arousal thresholds, they come down. So
Sure.
I think RERA, when you classify sleep disorder based on the score, for me, it may not be right way, because I will give a lot of importance to RERA, because that shows
Sure.
that you're getting into a fatigue mode over the years.
Yeah. So important points. I agree with what Neil has said and Partha has said, but I'm not a sleep physician, so I treat sleep as a part of my general respiratory practice. So I'm not as passionate as a lot of people on this platform. So I say this as an outsider with lesser knowledge as compared to what Neil and Partha has. So my take on it is, you need to be a little cautious about treating people with a low AHI or a RERA which is mildly or moderately raised, simply because the tolerance of these people to the interface, to CPAP, is also low, and that there's good literature to show it. I completely agree that if you treated these people early, you might prevent the comorbidities from progressing, and an effort needs to be made to pick these people up early and treat them. Completely agreed. But you need to watch these people cautiously. Let me come to Shraima. Shraima, I've got a question for you, but before that, I know you had a comment about this. So if it's anything different to what Neil and Parthuda says, your comment, please, Shraima. You're on mute, Shraima.
What I wanted to tell, I think Dr. Partha and you have also spoken, but just wanted to put in a word that scoring of RERA is only optional. So most of the polysomnographies which I see being done and brought to me, they don't score RERAs. So in clinically speaking, how I look at RERA is, if a patient is symptomatic and at the end of a level 1 sleep study, you get a low AHI, then you go back and see whether you have missed any RERAs, so that could be contributing to patient symptoms, and that you might miss if you're only looking at AHI.
Sure.
So
Sure.
that's why manually looking at sleep studies and level 1 studies are important.
Yeah. So I think Shraima makes an important point, close to my heart. The fact that when you're interpreting the sleep study, that's where all the questionnaires, the symptoms, the history taking that Partha spoke about, the pre-test probability becomes important, and the comorbidities become very important. And you interpret both the AHI and the RERAs from that context. I know you had a hand up, Neil, so I'll come to you in a moment. But Shraima, quickly, the question that I had for you was about sleep disordered breathing and OSA. So two different compartments.
Right.
How do you differentiate between the two? Do you think in our scenario, general respiratory physician doing sleep, it's more or less the same thing, or do you think the distinction is important? And what are the diagnostic criteria of OSA? Very briefly, Priya spoke about it in great detail. So briefly, and then I'll come to you, Neil, I promise.
So technically speaking, sleep disordered breathing is like an ICD-10 term in which it includes both obstructive sleep apnea, central sleep apneas, obesity, hyperventilation, all other hyperventilation syndromes, sleep-related So it's an umbrella term. It encompasses a lot of sleep disordered breathing. There are subsets. So OSA is the major chunk. In your clinical practice, 90% will be obstructive sleep apnea. So sleep disordered breathing for a general physician or a general practitioner would be OSA, but those terms should not be used interchangeably. Like, those are different. Sleep disordered breathing is an umbrella term. OSA is the major subset. The criteria for diagnosis, it's been repeated multiple times already. So we need a polysomnography to diagnose. And in a symptomatic patient, an RDI of more than 15. And if a patient is not in a symptomatic patient, an RDI of 5 or more is needed for diagnosis of OSA. If a patient is not symptomatic, an RDA of 15 or more is sufficient. So important thing, it's not only AHI, even the RERAs are also included in the diagnosis.
Sure. Grand. Thank you, Shaima. I'll come to you in a moment, Mohan. But before that, Neil, you had a point. You had your hand raised. So quick comment.
So just because that discussion I felt, so sir, I'm not just saying that we look, because you discussed regarding RERA, it's not RERA in isolation. It
Sure.
was that comparison of AHI and RDI. So
Sure.
RERA will be because apnea, hypopnea and the RERA events cumulatively will be looked at RDI. So compared to the two indices, that is AHI or RDI, RDI is relatively, that was the thing, not in isolation the rare events. Is just what I wanted to say, sir.
Yeah, grand. Important message. I think that's important carry home message for all of us. Let me come to you, Dr. Mohan. So, Mohan, what is an epoch? And how do you read, how do you personally read a PSG report? And I'm sure what you do is what you would want others to do, but what's ideal was another part of my question. Mohan, over to you.
Yeah. So epoch, the classic definition of epoch is nothing but a period of time. So basically, as Dr. Priya has shown in our presentation, the previous sleep study used to run in papers, bundles of papers. So each paper was coming for a 30-second interval. So that how the 30-second epoch was started. So this epoch is a brief period of this 30 seconds. In sleep study, we called as every epoch is a 30-second epoch. So our duty as a sleep physician, once we interpret this polysomnography report, we should make sure to see the stages in the epoch. Ma'am?
No, it's okay,
Yeah,
Mohan. Go on.
yeah, we should see the stages of the epoch. Basically, once you see the epochs, we, as already ma'am mentioned, minimum 4 hours sleep of the patient is required. And once we do a manual scoring, or as Dr. Partha has mentioned about automatic scoring, whatever we are doing, is all everything is based on this epoch. So the machine calculates, or we calculate based on the stages. If an epoch has got more than 2 stages, then we should take the maximum point of the epoch, which stage occupies a maximum portion to be the particular stage. So the common stages which I'm telling is about the wake stage, N1, N2, N3, non-REM stage, and REM stage. These are the common stages which we score. So these all based on the activities of the bands, the alpha waves, the theta waves, delta waves, and beta waves. So we should be make sure what kind of waves we are seeing in the particular epoch. So that gives us an idea what stage the patient is in. So whether it is a slow wave or theta wave, or it's a fast acting wave, whether it's an alpha wave where the patient is completely awake, but more than 50% the epoch showing an alpha wave. So then we can identify the patient is still awake. Then is it the fast waves, whether it's a sleep spindle. So these are the subtle things which give us gross information about the stage where the patient lies at the particular point of time. So in that way, we can calculate the stages of the sleep. We can identify the total sleep time, not the total recording time. We can identify the total sleep time, the various stages, and the problem from which stage has been arise. Whether it's a REM sleep disorders, the problem happened in the REM sleep, whether it is a mid-sleep one, whether the patient gets more of insomnia propaganda, where the patient have more of wakefulness. So these short-term things can be easily identified with simple epoch. All the epochs will be sequential. It should be sequential. You can't jump off from one epoch to another 30 seconds. So that is the most important thing. Should do a sequential epoch test.
Grand. So very detailed, lovely answer. I've got nothing to add, Mohan. There was another bit of my question, which was about reading a PSG report. So you've described that adequately. Do you think that a machine generated report, I mean, there's a lot of people who are listening to us today. A lot of them would not be in a position to score reports. So how do you think the machine reported scores versus when you're scoring yourself, how much does that vary? What would be your recommendation to people who aspire to become sleep physicians going forward? Do you think it's important to read the reports individually, or do you think a machine generated report does the same in most cases? Mohan.
In the advent of time and the availability of manpower, so doing a manual scoring may not be possible for all the people in all places. So there, the auto scoring can be done, but as you there will be underwhelmed report. So some patients we might miss the actual AHI or the actual quantum of the problem. The machine might report it underwhelmingly or lesser area. Sometimes it can miss the important events. That's where the manual scoring comes a very important tool. I do agree. In our setup, we have a people of technicians who can do manual scoring, which gives more amount of time for us to treat the patient. But in certain places where that may not be possible, so in those cases, auto scoring can be done. But I do prefer doing a manual scoring first.
Yeah. So I think with artificial intelligence, gradually the auto scoring will actually get better with time. The precision will increase. But I completely take your point. Important carry home message. If you have the facility, if you have the technicians, if you have the time yourself, doing it yourself is very, very important. Let me come to Dr. Priya Ramchandran next. Priya, this is, I think, an important question that I'm going to ask you from the audience perspective. Do you think, when do you look at a sleep report and how do you say this is a well done sleep study? versus something where you say, no, this sleep study has been not done properly, maybe a home done sleep study that you have to report. You say it's not adequate. And what would make you repeat a sleep study all over again?
Yeah, that's a very important question, because many a time people walk in with a sleep report. So you have to make sure that the recording time is at least for 4 hours. Anything less than that may not be enough. Of course, if in 1 hour, if the patient has 100 apneas, then it's,
Yeah.
I think, enough. But otherwise, technically, 4 hours is required, 4 hours of sleep. And that's the primary thing. Then we look at every channel and make sure all the channels are connected throughout. So sometimes what happens when the patient turns, the snore mic might come out, the height sensors might come out, and or if they've not put it on, the abdominal belt and the chest belt are not put properly, they may become loose with the patient turning over. So then the recording may not come out properly. So we have to be aware of those changes also. So if the machine scores the whole thing, it may not be able to pick up all these things. So we have to make sure that at least give a cursory look at the sleep study, make sure all the leads are connected, have recorded adequate amount of the signals, and then go with the numbers.
Yeah.
And a sleep study may need to be repeated if the basic channels like your hypoxia is not recorded, or the chest movements are not recorded, or the airflow is not recorded. Then the study for a predominant period of time, then the study needs to be definitely repeated once again.
Yeah.
And again, it may be repeated if the patient, the number that you get, AHI, is not matching the patient's symptoms. Sometimes we may have to repeat the study to make sure we've not had a one night phenomenon. The first night of sleep because of the discomfort or the stress, patient hasn't slept well, then our numbers may not match up. Then we may have to repeat the sleep study.
Yeah. So a brilliant answer, Priya. I think this is a scenario we face quite often. I mean, I'm not sure how many people at St. John's would actually walk in with a home done sleep study. Probably the number is not as large as the ones that I see. And I think a lot of these sleeps, it's like doing spirometry. If you just look at numbers without looking at the flow volume loop, the numbers can often be fallacious. It's the same with a sleep study. That's
exactly.
If you just look at the AHI and the RDI, you might come up with a number which has no relation with the actual sleep study, which has been done inadequately for the reasons that Dr. Priya Ramchandran spoke about. So I think very, very important message to look at the tracing that's been given. A lot of sleep studies done at home, which are supported by industry, are not done the way they should be. And that sort of is an important stratification that needs to be done in our country going forward. I know Parthuda has his hand up. So Parthuda, quick comment, please. Parthuda, I think you had a comment. So quick comment, please. Dr. Parthobos, did you want to add in a quick comment, or did I just see your hand up wrongly? Okay, let me go forward. We'll come back to this, but quickly, there's this question about the different levels of sleep study again that I think we need to reiterate once. And I want one-line answer. So let me start off by asking Neil about level 1 and level 2 sleep studies. Where would you choose a level 1? Where would you choose a level 2, Neil?
Hello. So level 1 compared to level 2, again, ideally in patients, level 2 is where we are doing a home study. And at that time, in such cases, first would be more important is where we cannot do a level 2. We should definitely do a level 1. So if patient has a cardiorespiratory comorbid illnesses such as CHF, congestive heart failure, COPD, stroke, if we are thinking of a mixed sleep disorder such as central sleep apnea, if there is likelihood that the patient has a very poor home setting or poor compliance, if there is so in such cases, definitely we cannot, like, we do need a level 1 study only. Now we do have now data for level 2 studies where there is a high probability of moderate to severe sleep apnea, where the patient does not have significant comorbidities, where there is a stable sleep wake schedule. And the a lot of times in India we have cost implications also, and sometimes even for patients, the sleep environment in a sleep lab compared to their own home, that also helps. Now this is just, if we look at practically data wise, like there was a Cochrane study done in 2017 which showed that portable level 2 studies had similar diagnostic sensitivity as well as specificity compared to an in-lab study. Even the ASSM guidelines 2021 show that in cases with high pretest probability of sleep apnea without significant comorbidities, a level 2 study can be done. And but still the take home message would be that ideal study has to be a level 1. But if you have logistic limitations, if the patient does not have comorbidities or a mixed sleep disorder, then in such cases level 2 study can be done.
Sure. So important message. So Neil spoke about comorbidities. He spoke about complex sleep apnea. He spoke about irregular sleeping schedule. So you can see there's a long list of conditions where you would prefer a level 1 over a level 2. However, I think it's very important to remember that the studies show that a level 1 and level 2 matches in our experience. And I think this is speaking on behalf of the entire panel here. We feel that in our country, a level 1 adds far more information as compared to level 2 whenever the pretest probability is not very high. I think that's probably the only scenario. Shraima had her hand up, and I don't know whether Parthuda, can you hear us?
Yeah, there was some problem.
Yes, I came to you a couple of times, but you could.
I just wanted to add here something. So can I add something?
Yeah, please. Yeah,
quickly. I can see a lot of audience are there. So very important information I want to give across the audience. Look, Dr. Priya was mentioning about the sleep report. I think one thing categorically which I tell my residents and all, whatever the sleep report you're getting, whether it's a company driven or unattended or level 1 or level 2, the way you write an ECG report, the way you write a CT scan report, the way you write an X-ray, you should be very systematic. And that is a message, if it goes very loud and clear from this. I just want to read out, I just noted down few points. The first thing is you should know how to write a sleep report. I'm sure even the best of the pulmonologists also, they don't write the sleep report. They say that CPAP response.
Sorry to interrupt. Just the points that you mentioned, we are running out of time fast. I just want lots of questions to take. Yeah, please.
One thing I want to write here is that when you do there is some first thing you have to write the sleep stage breakdown. Total sleep time should be written always. Then the sleep latency is very important because how long it takes to fall asleep. Third thing is wake up time after the sleep onset. It's called WASO. That also is written. Then sleep stages, and last is sleep efficiency.
Sure.
In the respiratory events, you write the RDI and HEI, but the most important thing is that people don't write about the physiological variance, the heart rates. Many times you have fibrillations, and I think that should be, and the desaturation and the periodic. So I think you can classify your report about the sleep stages, respiratory variables, physiological variables, periodic, and that makes the sleep study complete. So this can be always picked up from the report, whichever the level you're getting. That's right.
Yeah, but a very valid point. I think having these headings chalked out actually on a piece of paper when you're reporting it actually makes sure that you're not missing out on bits that you very nicely.
And also for medical legally, you're much more impeccable. People take you seriously, and they value your credibility.
Sure. So Shraima, I know you had your hand up. So quick comment from you about what you needed to say about this, and also a level 3 sleep study. Do you think you will ever do a level 3 sleep study out of choice? Or do you think it's only in areas where you don't have an option that you end up doing a level 3? Shraima.
Right. So regarding the comment, whatever the studies which you're quoting, which is equating the level 1 and level 2, what we need to remember is that these level 2s were scored manually.
Yeah,
So this
sure.
so we are not talking about automated report versus level 1. Even in moderate to severe OSA, all the studies which are showing that they were manually scored. That means somebody sat and reviewed the data before finalizing the report, which never happens in practical settings. None of the level 3 studies which I have seen, when the patients come with reports, none of them have been manually seen. So all they do is they just download the summary and then give you a report. So coming to the question regarding level 3, the only advantage is the convenience.
Sure.
Of getting the sleep study done. So most of our settings we have, I work in a public institute, so there is a long waiting period to get a level 1 sleep study. So in that case, if a patient has high risk factors, for when your pretest probability is high and you're sure that the patient does not have any comorbidities, then level 3 is a good alternative. But I generally upfront explain to the patient that this test is going to give a lesser number, doesn't mean that your disease is any less severe. So you have to, because I feel practically speaking, the AHI number actually convinces the patient to start treatment. So I upfront explain to the patient that it might become non-diagnostic, in which case we have to repeat a sleep study in lab. So the only advantage is the convenience and your ability to do it earlier, and at a cost, lesser cost also, if you are comparing with private institutes. But the disadvantages are very many. That is, main thing is that it always gives you a lesser AHI, because
Sure.
you do not have your sleep time, because there is no EEG data, and you do not know whether there are subtypes of OSA, like a REM dominant OSA or a position dominant OSA, which you would not pick up and which have actual treatment implications. Like if a patient is predominantly a supine OSA, and we have had seen a lot of patients who have a supine OSA, but in lateral position they do not. Their AHI is like around 5, in which
Sure.
positional therapy is like, you don't it doesn't cost anything, so you are losing out on treatment implications by doing a home sleep study. So
Sure. So
that's why
lots
you
of
have to
limitation, as Shaima says, lots of limitations. However, that benefit is you can do it at home. It's easy to do. And if you
convenience.
have a high test pretest probability, is something that you can opt for. I really like the bit where you spoke about talking to the patient, making sure that they're going for something which is less than ideal, less than what is warranted, and the prospect that in doing it early and maybe at a cheaper cost, you might end up having to repeat the test if the pretest probability is high and you end up with a negative report. So I think that's the facet that I think I would remember for future. Dr. Mohan, coming to you, what about a level 4? Would you, not yourself, but for the audience, lots of people who come from tier 3 cities, who come from the suburbs, rural areas, would you ever do a level 4 at all? And in what circumstances would you say that, okay, a level 4 can be done?
A level 4 is a test where the patient loves to have, but as a physician, we hate to give actually, because it doesn't give most of the things. It gives only about the pulse oximetry findings. We would
Sure.
definitely miss. It is more comfortable for the patient, for the caretaker, who are at
Yeah.
home. Very easy, all everything said and done, but it doesn't give any idea about how the patient slept or not, whether patients have any central cause, whether there's any insomnias, or whether patients having any other
Sure.
sleep time. Nothing can be interpreted as such. Even level 3 is much better. If you going for a level 4, I prefer giving a level 3 rather than going for a level 4, sir.
Sure. So point well taken, Mohan. I think the clear message is you would almost never do a level 4. It's just an overnight oximetry, which might tell you about desaturation, but nothing more. And hence, to actually treat based on a level 4, I sort of remember what Neil said a little while ago, is not just a hazard for the patient, it's a hazard for the doctor, because you would have medical legal implications because of it. So I think that's the message for the audience from us. I'll come to you, Priya. You've got a point which I'll ask you about. But I have an important question also for you to tag along with your comment, which is about a split night versus a full night and then home titration. What is it that you would advocate for people? And what are the different circumstances where you would advocate one versus the other? Priya.
Okay. The first comment was about a level 4. Probably if a person has to travel across to get a sleep study done, I will do a screening with a level 4. And then if there are multiple hypoxic events, then make him travel 500 kilometers to get a sleep study done. That will be one scenario where I can think it is definitely helpful. Then coming to your question of split night, yeah, again, in an uncomplicated patient, the ones that I had mentioned, those don't have any other comorbidities. The uncomplicated patient with a high probability of OSA can undergo a split night, but you have to instruct your technician very clearly when not to do a split night. Even in an uncomplicated patient, if the patient hasn't slept well, patient is very restless throughout the night, trying to put the CPAP is going to make him even more restless, a very practical thing which many people miss out. Then the second thing is the duration of sleep. At least 2 hours of good sleep with moderate to severe OSA has to be documented. Then only and patient should have 3 hours of CPAP time left over for that. If the patient is morbidly obese or has COPD or has type 2 respiratory failure or hypoxic, then the chances of requiring a BiPAP are higher. In that condition, definitely a split night shouldn't be attempted because you will not have time to go over from CPAP to BiPAP. So definitely the 3 hours window is not enough. So that would be the indication for a split night. And home sleep, home titration, if the number of RERAs are not too many and the patient is uncomplicated OSA, patient can go ahead with the home titration. And we can, one advantage is over a period of 1 week, we can see the whole trend over 1 week rather than a single night event and give them a report. And now with the cost of the auto CPAP and the fixed CPAP nearly being the same, though all the studies are being done on the fixed CPAP, we can still prescribe an auto CPAP also.
Sure. Yeah, grand. I think that's a lovely answer. I won't dwell on that. We're also running out of time. So I'll come to Parthuda next. Parthuda, home sleep studies. I spoke briefly about my disillusionment about home sleep studies in this country. I wondered whether in your practice, in your clinical practice, rather than sort of data that's published, which is mainly from the Western world, where do you position home sleep studies and the future of home sleep studies in this country? How do you see it?
Dr. Raja, I think home sleep study is a very beautiful concept. I'm for it. The reason being, provided you have got a very good trained team, because we regularly run the sleep technicians programs. If you have a good technicians who can communicate now with the technology coming, I think our home studies are much more effective, because what happened, homes gives a sense of familiarity. But the most important is the sleep. You get into the sleep with your own pillow, own bed, the comfort level is very high. So if you can do a proper home study with a good technician, and also you have the wearables and nearables, which is coming these days, and with the new technology coming, I find it's a huge future, provided, as I mentioned, you get the right data, your technicians' quality should be good. And I'm very, very comfortable. In fact, I prefer home studies over my lab studies. I've got both the facilities available. People many times complain that they are more comfortable at their home environment.
Sure.
Familiarity.
Sure. Point well taken, Parthuda. So I don't think I am for a moment doubting the fact that even if I had needed a sleep study, I would be happier doing it at home rather than doing it in the sleep lab. My disillusionment is my patients coming in with a sleep study done by a technician I have never seen or never heard of, with a suboptimally done sleep study with which I have no relation. So that's where my disillusionment stems from.
Yeah, one more thing I have to add.
Yeah.
I'm talking about moderate with uncomplicated, no comorbidity. If you have cardiovascular, because the biggest problem of sleep apnea is the cardiovascular consequences. If you have elderly people, severe comorbidity, uncontrolled diabetes, atrial fibrillation, poor ejection fractions, no, absolutely no.
So all your level ones, isn't it? So all the stages places where you would do a level one, you would
clean, uncomplicated, good technician, I'll go for it.
Yeah. No, absolutely agreed. So the message that I'm trying to give to our audience today is a lot of you, I know, depend on the industry and people you don't know to do home sleep studies for you. You don't have access to technicians the way Dr. Bose spoke about just now. People who are trained by him, who know what they are doing. You do it with unknown people. and then you go by a number, an HI and RDI, and you prescribe a machine to these people. That's not the way forward in sleep medicine anywhere in the world, including our country. So that's one message that I wanted to give to people. But I completely agree with what Parthoda said. If you have access to good quality technicians, if you've trained them yourself, you can believe on them, depend on them. A home sleep study anywhere in the world, including India, is far better than one that's done in the lab. Completely agreed there. Let me move on quickly and come to Neil next. Neil, this is right up your street. So wearable sensors, watches, there's lots of questions in the question box about them. So I want a brief summary, a 5-liner from you about how you position these, the fact that these are being promoted right, left, and center. Your Apple watches that you have nowadays pick up lots of data. How reliable do you think these are? Do you think these might actually replace doing sleep studies going forward in the future? And how do you position them in sleep practice? Neil.
So thank you. And like you mentioned, it's and it was discussed earlier also, it's a very strong commercial market here. Now, number one, that regarding that any smartwatches or any rings or any modern devices which can help diagnose sleep apnea, clear answer that it can never replace a sleep study. It is a very clear thing. It cannot replace a level 1 and a level 2 study. However, as a early screening tool, so now even the FDA last year in last month in May in ATS, they've also approved a device called as an ApniMed. It's a ring which now initially these all variables were just checking regarding the oxygen saturation, the heart rate variability, the sleep related breathing patterns. Now this in ATS just last month, Harvard School actually came up with a sensor based digital health technology. It is called ApniMed. Now what they studied is that with the SpO2, with the pulse rate, with the motion sensing abilities, it can detect an oxygen desaturation index, a time below 90%, hypoxic burden, heart rate response, and heart rate burden. So what they implied through utilizing all three parameters is that, and that too not a single night study. They have trials across almost 51 cities. And what they do is over a period of 9 nights, over a period of 47 days using these rings, they were able to kind of correlate this with sleep apnea data that these are actually the future. That is why they've got approval from the FDA. Same way Apple has got last in September, October, even in India, the recent watches do provide sleep apnea data. But very strong, clear message has to be the American Academy of Sleep Medicine guidelines or any evidence-based literature, whatever data is there, is against using any of these latest devices for standalone diagnosis. It is clear that it can be used, but in as a screening modality or somebody with symptoms, you can utilize it that this patient will need a sleep study. Also, with that, in the just one case scenario in India that we have cases in India reported last year. There was, especially in South India, I think one case was reported where this modality can even help you as a life-saving tool if you monitor this in your patients. So if a patient had just got tachycardia at night, eventually with hypoxic events occurring, went to the doctor on evaluation, the next day was found to have a saddle pulmonary embolism. So my point being that if we utilize this technology practically with your history and scenario, it is a very strong additive tool in your armamentarium to your diagnosis, but it does not replace it in any form compared to the standard polysomnography. Definitely, there is more scope of research in this. That would be my message here.
Sure. So, Partha, I've completely run out of time. I need to go through some of the questions in the box also, and we'll all be starving tonight. Dr. Priya Ramchandran has already told me that she will start her REM sleep at 10:30, so I have to keep that in mind. So, let me sort of quickly go to Shaima. Shaima, so carry home message from Neil, I think, is this is probably the future. Please don't try this as the sole modality for diagnosis of sleep apnea. It's not gold standard today and it's unlikely to be tomorrow, but screening for sure for follow-up of patients is useful. Let me come up to Shaima with this non-obtrusive contact-free recording. What do you think about this cloud-based recording? What are your thoughts about this, Shaima? Short answer, please.
So again, following what Dr. Neil Thakkar said, it is even more rudimentary, contact-free testing in the form of sensors which you place under the mattress, or smartphone-based, in which you keep the phone a little away from you and that records snoring. Again, it is more rudimentary than your wearable sensors, but probably it is like your questionnaire.
Yeah.
It can be it just sensitizes the patient. The only advantage I feel is that these would make the general population aware about sleep, importance of sleep, because they give you these data. But other than that, these are not for diagnosis.
Yeah, grand. So clear messages from our side. The last one is for you, Mohan. So Mohan, about OCT, so optical coherence tomography and MRI. How do you position them aside from being a research tool? Do you think there's any position for them at all in the work of someone with sleep apnea? Yes, Mohan.
The role of OCT we generally see in ophthalmology departments,
Sure.
but in the OSA component, it gives a clear clue. The precision-based obstruction level can be identified. Whether
Yeah.
it's retroglossal or retropalatal, where is the level of obstruction can be based on precision. It can be identified. Nowadays, it's upcoming tool in the role of OSA diagnosis. At the same time, in MRI, we have the dynamic MRI where the patient is sedated in the MRI console and we see how the patient sleeps. This being a MRI give more impression of soft tissue perception, so we can identify the level of obstruction. Both gives a level of obstruction, like kind of a dice where we give a drug-induced sleep endoscopy. We can
Yeah.
directly visualize the level of obstruction. These are
Sure.
less invasive ways to identify the level of obstruction. But
So
at present,
complicated sleep apneas, complex diseases, structural diseases.
just
I
majorly
think
to
there.
plan for the surgery, this might be very much useful,
Sure.
sir. If you're
Yeah,
going to
that's a
plan,
great point.
where's the place where you have to go for the surgery, which level, where is a
Sure.
multi-level obstruction or a single level obstruction. So that can be
Sure.
identified.
Sure. So I'll come to Priya with my last question, and then we'll take some questions. I've got about 150 odd questions, more than that actually in the question box, probably many more, which I cannot count. So we'll take a few. But before that, one question for Priya, which is sort of our conclusion from the panel side for today. So amongst the currently available modalities, what would be your choice in diagnosing? So the full bit, is it a level 1 polysomnography done in the hospital, or a level 1 or a level 2 done at home? What's your ideal, Priya? If you want a
Ideal would be
message.
a detailed history,
Yeah.
a questionnaire,
Yeah.
examination, make sure there are no comorbidities, and then if everything is perfect, a level 1. Definitely
Yeah.
a level 1.
Okay.
But
Okay.
if there are no comorbidities, your prediction is high, a level 2 or a level 3 can be done. But if there are comorbidities, better to go ahead and should go ahead with level 1. Even if there is a small risk of arrhythmia, a cardiovascular involvement, a previous history of stroke, any other comorbidities, just close your eyes and go for a level 1. Don't budge to anybody's pressure. Level 2
Wonderful.
can be done, but preferably level 1.
Grand. So clear message from the entire panel. You've heard us repeating a few times. There's actually a question at the bottom, which I'll start off with for you, Priya. So there's a question which says that all of us on the panel, so Dr. Sandhya, who is from Maharashtra, Mumbai, says, as per lecture, what I found the panel not recommending a level 3, but in level 3 type using PPG technology, sleep report contains an AHI, a REM, an AHI, ODI, and RDI, VASO, SL, SE, heart rate, etc., etc., etc. So the question I think is, why are we as a group against level 3? I think, so I'll put in my one-liner, two penny worth, which is, I don't think we are saying you don't do a level 3. We are just telling you that you get less information doing it. And if there's a question of comorbidities, if there's a question of looking at complex sleep apnea, if you have an altered sleep pattern, there's a risk of there being an overlap syndrome, for instance, COPD along with obstructive sleep apnea. All of those scenarios, you're better off doing a level 1. Anything to add, Priya, as a message
No,
for
sir.
Dr.
I think
Sandhya?
you've summarized it beautifully.
Okay, let me come to a few questions from the question box, and I'll start off with Parthoda. Parthoda, there's a question about questionnaires again, and two questions actually. One question is about any scoring system which is specific to India, And the other question is, the questionnaires that we spoke about, have they been validated in India, any of them, which you use in your practice? Parthoda.
Yes, these are the questionnaires which are available, the F1 sleepiness scale, stop bank questionnaire, and all those. We definitely use it. But what we have done in our society, we have used a couple of more factors, which is coupled with your sleep history, which I told you, a clinical, your Malapati score, abdominal circumference, and metabolic parameters are very important. So we have included uncontrolled diabetic is another factor, which is
Sure.
another factor we have included. So metabolic parameters in the form of diabetes, hypothyroidism, increased truncal obesity,
Sure.
Malapati scale, coupled with the questionnaire which is available.
Yeah.
And one thing we'll always tell our patients, the sleepiness and fatigue scale. There's a scale called fatigue scale.
Sure.
So whenever you assess the sleepiness score, see to it that patient is not into alcohol, he's not on benzodiazepines, he has slept well, because these are all can give you a confusion to assess your sleepiness score. So
Yeah.
these has to be ruled out.
Sure. And this questionnaire we've added in the controlled diabetes bit, etc., is something that's sort of validated and available in the space that we are talking about, Parthoda?
We are using it in our level because we have quoted in our Indian sleep disorder, Indian ISDA, we have mentioned about it. We are following it. In fact, myself, Dr. Surya and Vikram, we have done a scoring which we follow in our level.
Wonderful.
But definitely, we have done about in 500 patients. We need to do more.
Yeah.
We are coming up, in our this SleepCon, we are coming up with this score, which
Yeah.
will come to more.
So, Parthoda, the reason I was asking this question is, if it's something which is validated, used in 500 patients, if it's published, then maybe all the listeners, there's sort of such a lot of
we can
people.
share the link.
If you can share the link for it, then it will be great. I mean, people can use it.
But one thing I'm telling you, use your clinical tools and metabolic factor also when you do the
Sure.
sleep.
I think that's an important message. Put in the comorbidities, especially the uncontrolled ones, the severe ones, into the scoring that you're doing. Add that to any scoring that you do. Let me quickly come to Shraima. Shraima, there's a very interesting question, important question, more than interesting, from Dr. Tina Anand from Delhi, who says, what is the meaning of the word compliant? You speak about being compliant to CPAP. What time frame are we speaking about when we speak about being compliant to CPAP? It's therapy here, but I thought that's a pertinent question even for today.
So that is a very important thing when you follow up such patients with sleep apnea when they come with CPAP. So what I advise is for all my patients on CPAP to come with the CPAP usage data. So that gives a lot of information about how much the patients are using. And to say that, so the basic things is that generally what we target is at least 70% of complaints. But I always emphasize to the patient that the more they use, more likely that they will benefit from the treatment.
Yeah.
And another thing is that at least 6 hours of use is required to reduce your sleepiness. So that is the general target for CPAP compliance, 70% and 6 hours of average nightly use.
Sure.
But you always emphasize that the more you use, the more likely you are going to get the cardiovascular benefits and,
Sure. So very valid points, Shaima. Very nice practical pointers. I think there's a lot of literature that is available looking at less than 4 hours and more than 4 hours. So I think there's literature which is available, but like Shaima said very rightly, the more you use it, the greater the amount of benefit, both from the daytime symptom perspective and also from the comorbidities perspective. There's a lovely question, Neil, which comes from one of my young colleagues in Kolkata called Dr. Shopnomaya Ghosh. So he asks if patients with RERA and a low AHI, a mild OSA AHI, are subjected to lifestyle modification first and then followed up, and then if we start CPAP, will that not be better? So I'll tell you, I'll sort of translate the question to simple terms. What he's asking is, you have someone, say, with an AHI of 12, who's got a BMI of, say, 30, and does not have comorbidities, is relatively young. The patient comes to you. Would you tell the patient, after looking at the report, making sure it's a valid report, will you tell them, go and lose weight, diet, exercise, come back when your weight comes down, and then I'll repeat a sleep study and say whether you'd still need the CPAP, or will you give them the CPAP straight away? That's the question, Neil.
So, sir, in this case, you said that the patient's AHI is 12, and like we are in between, say, mild sleep apnea is there. So, in this case, definitely lifestyle modification would play a strong role, and we would recommend that we can watch for symptoms. If, however, we go with the stop bang questionnaire, we have the Epworth sleepiness score, we have tools with us for the like how severe. Suppose the patient is hypertensive, he has got a very high BMI, he has uncontrolled blood pressure with multiple drugs which are ongoing. So definitely without any comorbidities, young male, mild sleep apnea, we can wait, lifestyle modifications and monitor over a period of time. However, this same patient with the clinical background of any acute, like any comorbidities that can worsen the sleep apnea, in such particular cases, I would want to I would say the risk benefit ratio and accordingly treat. But we can definitely go with monitoring and lifestyle modification.
Yeah, so I think that's an important message from Neil. I think you have to individualize in these cases. There's no one rule fits all. I think there is option of asking your patient to change lifestyle and come back later. But there'll also be some people who are on with undiagnosed comorbidities. You need to watch these patients carefully. You need to make sure you start the CPAP early if these patients have any form of complicated sleep apnea. I think that's an important message. There's another very difficult question, and I won't ask this to anyone. So anyone on the panel, feel free to answer. I know Priya is still there. So anyone who wants to answer. There's a question about children and whether the diagnostic algorithm needs to be changed in case of children, especially with obese children, especially with ones who have craniofacial abnormalities. So anyone who is going to volunteer for this difficult question, please do answer.
Can you repeat the question? Can you repeat the question?
I will do. So the question was, Priya, I'll come to you. Question was, children, craniofacial abnormalities, obesity. So in children, does the diagnostic algorithm change at all, or do we exactly do the same as we did in the case of adults? Dr. Priya Ramchandran, please.
Yeah, in children, the weighting is not allowed because even one AHI of 1 is considered significant. So in children, the sleep apnea is supposed to have a great impact on their brain development. So that, and most of the children who have sleep apnea, it's a correctable cause, like an adenoid or something like that, which is totally correctable. So waiting on them is not allowed. So so the basic diagnostic algorithm of screening, questionnaire, and doing the sleep study remains the same. I don't think a level 2 or a level 3 sleep study can be done in a child. A level 1 only has to be done, and then followed by treatment according to the cause of the others. Of course, craniofacial abnormalities and all are a big challenge for even use of CPAP.
Yeah. And I think in children, I mean, I'm asking you, Priya, rather than stating, in children, the threshold of doing a sleep study also needs to be lower.
It's much
because
lower.
Your symptoms are going to be far more complex. It's not going to be your straightforward sort of...
it's not going to be sleepiness. It will be jitteriness, ADHD kind of presentation.
Hyperkinetic children and so on, isn't it? So
yes.
Yeah. I got a question for Parthada. I think we'll finish off with 1 or 2 questions and then we're done. So this is from one of my esteemed colleagues, Dr. Parvez Kaul, who asked this question from Sher Kashmir in Jammu. So JNK. So Parvez asks, in low resource settings, what are the basic minimum requirements to implement an effective OSA screening? So screening being the operative word, and then diagnosis at a community level. So what do you think are the basic minimum requirements in a sort of primary care setting? What do we need to implement in our country to make sure that all these people in tier 3 cities can access care?
Yeah, Dr. Raja, the first level is that the whosoever is screening, he should be educated that the clinical algorithm, there should be a very head to toe, the clinical, the score, the basic, the sleepiness score and the head to toe analysis. They should look for the structural abnormalities, the cluttered, malapatti and all the things. Then, of course, the least what they require is a pulse oximetry, oronasal transducers, These are the two things coupled with, these are the least what I'm talking about, and to assess and a snoring evaluation. So one, the snoring evaluation at transducer, nasal flow, and a pulse oximetry. But the prerequisite has to be a very good clinical questionnaire and educate those people that 80% they should be very sure it is something that they are suspecting. Definitely they should use these three tools.
Yeah, yeah. So I think very, very important points Parthoda makes, and thanks to Parvez for asking this question. I think this is somewhere where a good history taking and a structured questionnaire, one of the questionnaires that we spoke about, along with doing things like the stop bank, doing a Epworth sleepiness score, maybe doing a level 4 sleep study here, just a screening would actually in primary care in the community is something that you could do. The patients, I think Mohan made a very important point a little while ago, or Shrima also did, the fact that these patients need to be counseled that this is just a screening test. The diagnostic test will be later on if the questionnaire, the level 4 sleep study, etc., points towards a sleep study and it matches your symptoms. And I think
one more thing I just want to add, you're keeping yes. the development of sleep in the future. There's a very interesting tool which is coming, which can be a very useful community tool. Definitely, of course, the questionnaires are very important. The clinical is a PAT. This is what the peripheral arterial tonometry is going to be one of the part changing in.
Very important.
This PAT is going to change in America. Already is changing. It's very accurate because it calculates your sympathetic resistance and also your apnea evaluation. And PAT is quite sensitive as an indicator. PAT could be a very useful tool in Indian scenario, coupled with a good structured clinical questionnaire as a clinical tool, a peripheral arterial tonometry. One can use, and it's affordable.
Sure. So Parthoda makes a very important point. So remember, guys, this is not this is not diagnosis. This is screening we are talking about. And we are not talking about replacing the gold standard, which is polysomnography. This is all cheap things that can be accessed in the periphery, things which are easy. And hence, that's the recommendation from all of us. It's not about replacing sleep studies. I thought I saw Neil's hand and then we'll wrap up. Yes, Neil.
So just one point here, that if we at a community level, we definitely have modes by which we can set up screening parameters. But with that, even as we are talking about the Indian Chest Society, so many pulmonologists are logged in right now. So even community, government and any NGO initiatives for therapy, because whatever you do, if you are able to diagnose a sleep apnea at the community level, the major prerequisite or the thing is that you should have a treatment option which they can afford or they can get. So either the government or there are definitely the government is also providing support. There are NGOs nationally in cities. But if, like, as an example, in our city, I'm in Vadodara right now, we have the Baroda Chest Group, which does provide oxygen concentrators for patients with on a rental at a limited time basis. So similarly, if we can have some initiatives where machines can be provided with the industry support, definitely, but that makes sense with the screening modalities, definitely.
Absolutely. So Neil makes a valid point, guys. He says there's help that's available if you want to set up a service. You need to access help. You need to reach out. You need to find out where the help is available. And if you did that, you could set up a service where screening and even some diagnostics is possible. So this is for everyone listening to us who are from areas which are more remote as compared to where we practice. There's help available, guys. The government provides help. There's NGOs, there's organizations which provide help. I'll come to you, Mohan. Very last comment before I finish off. Something that you wanted to say, but along with that, in the next 10 years, Mohan, when you sort of grow and become my age, maybe, what do you see the future of sleep diagnostics? Where do you think we will be compared to where we are today? What does the future hold? A brief answer, please, Mohan, because I'm famished and need to have dinner. So, yes, Mohan.
Same, sir. The patient definitely will be bombarded with many sleep reports, comprehensive AI-driven reports from the patients. The patient will walk up to a clinic stating that they have certain instruments which have alerted they have sleep apnea. So that will be there in the near future, I guess. We'll be getting more amount of patient-related awareness and more amount of unusual complications and confusion, chaos can happen because many technology may not be perfectly approved. but they might
Sure.
pick up more cases of OSA, which might be alarmed because the OSA level is much more than the community which we are seeing in the hospital setup. So future
Sure.
will be AI-driven diagnosis
Yeah.
of OSA,
Sure.
and maybe myofunctional therapies or hypoglossal
Yeah.
nerve stimulation or reduction in the size of CPAP, whatever, which is more compatible, might be
Yeah.
the more common attributive treatment for treatment of OSAs.
Yeah, sure, Mohan. And to just add to that, there's new drugs coming in, or we've not gone down that route because
Yes.
we've got other modules, other sessions which are in the offering today. After today, please listen into them. I have to say that I have been a part of lots of webinars during my lifetime, and I've never seen a webinar where we've got about 2,500 logins and people are still asking questions. And these are very distinguished sleep physicians who are far more experienced in sleep than I am. And that gives me a lot of joy. I've had a fantastic learning time with all my panelists. So, Dr. Priya Ramchandran, Dr. Neil Thakkar, Dr. Partho Bose, Dr. Mohana Krishnan, and Dr. Shraima. Um, Great answers. The Indian Chess Society and myself, as the secretary of the ICS, and Dr. Amita Nene. Heartfelt thanks to all of you for being a part of this wonderful discussion. Heartfelt thanks to the audience which has logged in and stayed until late and poured in their question. There's apparently more than 260 questions in the question box, and people are still asking questions. And it's 11:15 today. I think we could go on with the questions all night at the cost of all of us having a hypoglycemic attack and falling asleep. So, thank you for being there. Thank you for all the questions, all the participation. Thank you to Cipla again for being as supportive as they have been. And look forward to further modules of this sleep disordered breathing course of the Indian Chess Society. Do log in even in the future in larger numbers and listen to us. Thank you very much, guys, for being there for us.
Thank you, sir. Thank you, Dr. Amit.
Thank you so much.
Thank you, sir.
Thank you,
so
sir.
much.
Good night.
ICS team.
Thank